So here's a few questions, and we've got Zara and we've got Jack here to take your questions. Assuming someone has multiple tick bites, is it difficult to differentiate an EM rash from the other tick bites? Would either of you like to take that one?
Zara, why don't you give it a try?
Differentiating the tick bites from the other erythema migrans rashes, was that the question?
Identifying which is an EM rash as opposed to, you know, a tick bite, just where they've been bitten.
It's tricky. It's tricky. So there are some really nice images on the NICE website and some of the Lyme disease charity websites. So Lyme Disease UK, Lyme Disease Action, and the LRC website, and some of the American research websites. And you have to kind of get a picture of what Lyme erythema migrans can look like, because it has multiple different appearances. If they've got systemic symptoms alongside the rash, then you're looking at erythema migrans, you're looking at illness rather than just a localized thing. If it's it's tricky. It's tricky. I mean, if there's a clit, like the question is, you know, could this be just a local reaction, or could this be a serious infection? And it's a tricky one to tease out. If it's a different insect bite and you're clear that it's not a tick bite, then you know that it's not going to be Lyme disease. But you have to use your clinical judgment on that one. I don't know what Dr. Lambert and Anne would like to add.
No, I think that's it. I mean, people go in the Highlands and they get midgie bites, or people get a spider bite, or, you know, you can get bites from other insects besides ticks. And like I said, the challenge is that only about 15% remember seeing a tick or pull off a tick, you know, so you may miss the tick. But I think the key really is if you have somebody you know, in a tick endemic area, and they come back with a rash that's suspicious, and they have any kind of symptoms, you know, I mean, if you get a simple spider bite, you shouldn't be developing fever or arthralgias a week or two later. So I think you have to, it's challenging. It really is not that easy. I understand all of that, but you should have a high degree of suspicion based on your history and based on other symptoms they may have outside of the rash.
Could I add to that as well? Can you hear me, Arlene? Yeah.
Yes, Anne, you come in.
My feeling, and I've seen about 5 cases over the summer where a patient is calling about an insect bite. They're assuming they've had an insect bite, and they'll send you the photo, and you cannot diagnose it on the photo. And they've got no other symptoms whatsoever. But when you go into the detail, they have no recollection of a bite. They have, it's not hot, it's not itchy, it's not an allergy, it's not an infection. And sometimes in many cases, it's a diagnosis of exclusion. And then when you go into the detail, they suddenly remember, yes, they were walking through some fields 3 weeks ago. So it's important to actually always have it, every single insect bite, could this be an EM rash? The allergies are usually obvious, they come up instantly. Infections are normally obvious because they're getting very hot, maybe they're throbbing and they're aching. But an EM rash may have nothing else going on. And I've had at least 5 of those over the summer. And it takes a while just going into the history. Thanks.
That's really helpful, Anne. Thank you for that. Here's another one. I think this will be for Dr. Lambert. Would you give prophylactic treatment for a tick bite in pregnancy?
Well, the thing is, I'm not sure I'd give a prophylactic antibiotics for any tick bite. I guess that's kind of the situation, is that there isn't necessarily good guidance on giving prophylaxis. I think it depends upon the epidemiology of what's going on. You know, if you're in, one of my colleagues lives in Connecticut and he picks the ticks off his dog in the backyard, and he has a laboratory, he can do his own PCR. 70% of the ticks are positive for Borrelia and about 10% for myomotoi. So in that situation, if I get a tick bite, I think I'd want my prophylaxis, and it doesn't matter if I was pregnant or not. But I think as a rule, the guidance is not necessarily to give prophylaxis, you know, within the European Union. But I think you have to kind of be suspicious. And if the people develop any kind of symptomatology, then I think early starting of treatment, and it would be obviously amoxicillin if it was a pregnant woman, doxycycline, otherwise for anybody, you know, young adult and older. But I think there's some, I'm not giving you a definite answer here, but there isn't clear guidance on prophylaxis for tick bites.
Thank you. And there was a second question, which I think you've just answered, which was, would you treat prophylactically for multiple bites? So presumably the same principles applies. You've just answered there.
Yeah, well, exactly. It doesn't. If you're in Port Thumna, which is, you know, southern Galway, 15% of the ticks are positive. So, you know, it doesn't matter if you get 10 tick bites. You're probably more likely to get Borrelia when you calculate it, you know, but it's no different than exposure to any other infection, whether it's a needle stick or a sexual exposure to other infections. So I think I just think that does increase your probability of getting inoculated with something if you have multiple tick bites, but you have to make that decision and make that calculation based on if you know the epidemiology of what ticks are carrying in your community.
If I may briefly add something there, like when we think about mosquito bite prevention and malaria prevention, our first route of thought is, you know, use your insect repellents, use those mosquito nets, and we need to get into that mindset with regard to enjoying the outdoors. It needs to be common practice that we go out there with our insect repellents, that we cover up, we avoid long grass, we avoid you know, going off the path into the long grass. So then there needs to be concerted messaging out into the community that we have to approach the outdoors differently. It's still safe to use the outdoors, it's still fine to enjoy the outdoors, it's important, but there are ways of doing it safely, in the same way we wouldn't necessarily go out in midday sun without any sunscreen or not covering up. You know, we know that there are sensible measures. So, you know, there's public health measures and discussions that we need to have, and like we spoke about last time, that there are posters available, patient information available about using the outdoors safely.
Thank you for that, Zara. I'm going to take one more question. We've got a few in the chat box here, but I'll take one more and then we'll do the quiz again, and then we'll come back and do some more questions for those of you who wish to stay. So here's one from an advanced nurse practitioner who's saying they need to follow guidelines. So who would you recommend they ask for advice if they're seeing patients, presumably with suspicious ongoing symptoms?
Yeah, I think maybe Anne or Zara can answer that question, because you know the network in the NHS better than I do.
So what would a primary care response be there, perhaps, Zara?
So you'd be using the NICE guidance predominantly, but you said it was an advanced nurse practitioner. Am I right? Yes. So, you know, use the NICE guidance, but also kind of speak to the doctors that you're working with, show them the NICE guidance, explain to them your suspicions as you would with any other question that you have, and then take things from there.
Yeah, and I would say if you read the NICE guideline, it says if you have a clinical suspicion, you can treat. You don't need to have had an EM rash. You don't need to have seen a tick. If you have clinical suspicion, you're within the NICE guideline. So it's fine to treat on that basis. You've not done anything incorrect. Start with 3 weeks, plan to review them, and then change the antibiotic if necessary as per the guideline.
That's helpful, Anne. And of course, that's all in the NICE guidelines.
And I've just sent the link out again.
Thank you. It's in the chat box for you. You can also find the links through the Lyme Resource Centre as well to both the NICE guidelines and to the GP toolkit, and lots of other research papers that we've built into the research section there as well. So women who are treated for Lyme disease during pregnancy can be confidently reassured that there is no risk to their unborn fetus.
You are muted, Dr. Lambert.
Could I interrupt before then, before many people sign off? Number 3 is we've not given the answer to that during this.
Would you like to take that, Anne?
Lyme arthritis is not more typical. It's more typical in the USA, and neurological symptoms are more common in Europe, but we haven't quite got that message over.
Okay. Yeah, that is correct. There's different, like I said, there's different strains. Borrelia burgdorferi sensu stricto is not the predominant strain in the European Union. And people think that the Borrelia strains in America are more, bone joint tropic, and the ones in Europe can also affect joints, but it tends to be more neurotropic. So that is something we didn't cover. And then just the comment on Lyme in pregnancy. Not many studies done, unfortunately. But one of the original sentinel studies was Willy Burdorfer, who actually did pathological studies in a baby that died in Southampton, Long Island. And on autopsy, they actually found Borrelia in many tissues of that baby. So unfortunately, there's just case reports and some limited studies, but there seems to be evidence that there's clear evidence that Lyme transmits from mother to child. How commonly it occurs, we don't know, because there's never been any prospective studies. There have been studies looking at treating versus not treating pregnant women who had the EM rash and Borrelia in pregnancy, and there's less complications to the baby if treatment was given. But like I said, there is a limited data set, but there is transmission of Borrelia from mother to child, clearly indicated in the medical literature, in case report and studies that are not the best studies, but that's all we have.
Thank you for clearing that one up, Jack. Thank you. So that was the answer to number 6. So we're going to carry on for just a few more minutes. Very glad that most of you have stayed with us. Thank you for that. Here's a question, and I think this is probably aimed at and both Zara and Jack. Would you suggest that 6 weeks rather than 2 weeks of doxycycline would be a more realistic treatment for Lyme disease initially?
I'm going to leave this one to Dr. Lambert.
Right. Well, like I said, the USA guidelines, a lot of my colleagues are still saying just 2 weeks of antibiotics. The NICE guidelines have revised their recommendations, and it's 3 weeks of doxycycline, and that can be followed by 3 weeks of amoxicillin. So I guess I would err on the side of longer rather than shorter. I mean, we talk about antimicrobial stewardship, but then again, we give doxycycline for months and months for acne. I'm not saying we shouldn't be careful about the weapons we use, but if you look at the studies, if my slide said that 3 weeks of doxycycline, resolves early infection in 30 to 70% of the cases, I want 100% cures. So I've got no reservations about treating people for a bit longer, based on their symptom response. And I think that probably is a wise thing to do for the patients. If you treat a patient and within 1 week, all their symptoms are 100% gone, then I think you can make an argument just to treat for the 3 weeks. But many patients have persistent symptoms for weeks and weeks after. They get improvement, but they don't get resolution. That means to me that the antibiotics are working, but they haven't totally resolved the infection. That would be my assessment, because very often when people stop the antibiotics, the symptoms come back again. That means that the infection is relapsed in my simple mind. So I do think we should treat patients and not guidelines, and treat longer in situations where we think it's appropriate.
Thank you for that. Thank you for that. So I'm just flicking back because there was an interesting question here that came in about PANS. It said increasing numbers of children presenting with neuropsychiatric symptoms, PANS, have reported ECM prior to onset. Are you seeing an increase in the number of referrals for PANS arising from Lyme? So that'd be for Professor Lambert.
Well, the thing is, what is PANS? PANS is some kind of a disease, and then very often they do an ASO titer, a titer that is an antibody test associated with strep. Doesn't prove that they have strep, but there's an algorithm that they've decided this is related to strep and may respond to azithromycin. But then again, maybe there's other co-infections, including Lyme, involved in this condition. It does seem to be an antibiotic responsive infection. So it's, once again, it's poorly understood. We don't have any PCR-based technology to make the diagnosis. So there's going to be debate. But yes, I do think there's a lot of similarities between PANS and Lyme disease. And maybe in the future, when we have better diagnostic, we might find out they're the same condition.
Thank you. Thank you for that. Here's a quick question here. Do you know where we can find tick epidemiology data for the UK? Zara, would you have any?
There's quite a few. So if you just search on PubMed for tick data and say for tick and Borrelia, there's quite a number of studies over many, many years, mainly from the veterinary and ecology backgrounds, but there's quite a few. There was one that was recently released. You know, there's a couple based in Scotland, there's one in North England, and there's some based in Southern England. And generally the Borrelias that they're finding are Guarini, Afzeli. There's less so of the Bergdorferi, but it's still there. But there are studies on this, and it's just a case of searching on PubMed. Sometimes it's a bit tricky to find, but it is there.
Thank you, Zara. And one final question. There are more in the chat box, and I'm going to suggest that I hold those until next week, and we'll try and include them in next week's session as well, where we'll have Dr. Lambert back with us, and we'll also have Monica Wild, who's a herbalist, who offers some other options that you may want to think about, particularly for primary care where you don't have a lot of other options. So please do come back and hear that. We'll try and cover the questions. Here's the final one. For people who attend clinic with regular tick bites and are concerned about Lyme and who ask for treatment each time, would you always treat even if there's no other symptoms other than anxiety about getting Lyme?
If I could start with that one, I think that's a conversation about bite prevention. Because if they're a regular user of the outdoors, the question is, why are they getting so many bites? You need to be using an insect repellent that works for you, and sometimes it can be trial and error until you find one that suits. If they're worried about putting chemicals on their body, there are some effective insect repellents that are based on kind of essential oils and other matters, including one I think was involved with the research in the London School of Tropical Hygiene, and then about dressing appropriately when you're going outdoors, and doing regular tick checks when you're out there. So if they're getting regular tick bites and they're concerned about Lyme, which they're right to be, they need to be doing effective preventative action, and I think that's the conversation you need to be having.
I would also say that this is where the knowledge and confidence of the primary care clinician comes in. If you understand what it is that the whole issues around bites, around symptoms, you can be confident in explaining to the patient why they don't need antibiotics. It would be very negative to be constantly giving doxycycline for no good reason. So knowledge is, and it is maybe not even just people with multiple bites, even one bite, they'll come in a panic, wanting a blood test, wanting antibiotics. You need to have the confidence to explain why they don't need those things and when to come back if they do.
And we do this for other areas of medicine. You know, we comfortably have discussions about safe sex. We comfortably have discussions with regard to travel medicine and prevention. So this isn't beyond us. Maybe this is a case of having a wider conversation within the practice about how you have those conversations with patients and who are the best people to have them with. But it's not beyond us.
Thank you. It's actually a really good note to be ending on, is the whole idea about prevention. This is important, isn't it? In fact, we would all say prevention is better than cure. It falls off the tongue, but it's so critical in the case of Lyme. So on that note, I'm going to bring it to a close because you've given up enough of your evening, and we're just really glad to have had you with us tonight. Thank you to our speakers, to Professor Lambert, to Dr. Hussain, Dr. Cruikshank, and thank you to the team behind it all, to Gordana and Tina, for keeping everything running smoothly. It's always a challenge on Zoom, isn't it, to do these events. Thank you to you for your participation. We'll be glad to send out the links, as I say, after next week's meeting. And can I remind you again to fill in the evaluation form in your email? That's really helpful to us. So on that note, thank you again, and we look forward to seeing you same time next week for the third and final session. So I'll say good night and send you safely off to your kitchen, to that kettle again. Good night.